introduce our last speaker for this session, Dr. James Wheless, who I'm delighted to be in the same city with now in Memphis. He is professor and chief of pediatric neurology at the University of Tennessee Health Sciences Center, has a robust regional epilepsy clinic here and years of experience with patients with Lennox-Gastaut. He's going to talk to us today about current treatments for LGS as well as future opportunities. So take it away.
Thanks, Heather and Anne, for inviting me. And let me just pull up my slides here and we'll be ready to roll. And it's always a tough spot to be because I realize I'm the last speaker. I know we have a Q&A, but between people and food, and it's a daunting topic, which is to cover all of the treatment for Lennox-Gastaut syndrome, or LGS. So I'm going to attempt to do that. We'll go a bit quick, but the next 30 minutes, we'll really review this, and we'll see by the end of that to do this, you really have to understand treatment for almost all of epilepsy. So here's, oops, let me see if I can get to advance. There we go. Here's an outline of where we're going to go. So we'll just do a couple basic principles of treatment slides. We'll kind of look at therapies that are approved already. We'll look at rescue, and then we'll look at kind of future therapies and emerging needs. So let me just start off with just kind of, I think, general principles that are some you could argue not unique to LGS, but apply to spectrum of patients with epilepsy, but I think some that fit this group as well. And this has been touched on by other speakers this morning, but I probably don't need to remind this group, but this occasionally does come up because people say, gosh, these folks are so refractory, why are we continuing to try, or, we haven't responded to a couple of treatments. And I think we realize why. We just have to remind our colleagues that, it should be obvious, I guess, but that many of the more challenging seizure types these patients experience are, beyond the seizures, very dangerous to the family, to the patient. And because of that, tie up an enormous time and emotional component for caregivers as well, too. So they're just not, good. They're bad, and you can use other terms, obviously. And the goal is we don't want our patients to end up looking like this. Luckily, this is something we see less and less in our patients these days because of the treatment options that are available. But unfortunately, years ago was not that uncommon, and we still do see our patients that get injured from falls and other calamities that occur during their seizures because of the high seizure frequency. So we look at treatment with most epilepsies. Our paradigm is to start off with an anti-seizure medicine, or ASM, as you see here. We try a couple, we go to polytherapy, and if we're still having seizures, we kind of reevaluate and say, okay, have I missed something? Do I need to redo, testing of what sort, video EEG, make sure I know what's going on. And then we kind of figure out, what are the options? And I've outlined here, and basically there's 4 boxes or silos, if you will, that we talk to patients about treatment of their epilepsy currently. We'll eventually get to a 5th box, which I didn't put on here, but we're just starting, but it's not quite there for prime time yet, I get, which will be, gene or genetically based therapies as well. But the reason I bring this up is I just want to make sure it's very clear. When we talk about our patients with Lennox-Gastaut syndrome, we're not really thinking that, okay, if we reevaluate you and just go to one of these, that, you'll be set and kind of, wow, we're done, we figured it out, and we got the right treatment. I would argue that if you're seeing folks with Lennox-Gastaut, you really have to have all 4 of these kind of silos available to your patient and as part of your treatment armamentarium. And if you don't, you're really not going to treat that patient well. So the key is kind of over time individualizing these to that patient and figuring out, which patient, which of these will help for, and trying to use them in combination. And we'll obviously never have randomized trials that tell us the answer to that because of all the possibilities involved here. So that's where you really need the experienced clinician to be able to talk to the family and discuss risk benefits with their unique situation and make this decision of which pathway we go down next. And then the other thing I always remind families is, this is not let's make a deal. So if we go down a pathway we don't go as well as we'd like, the other doors are still open, if you will. We can still look at the other options. And I think a lot of families kind of lose sight of that. So now I want to move from kind of quick background, kind of philosophical approach, if you will, to the specifics. So, and I'm going to call these the kind of the Wheless 10 rules of treatment, if you will. Some of my colleagues have called them the 10 commandments. I won't be that, go that route. But just general rules that I think if clinicians followed, our patients in general will be much better off. Are they going to stop all of the seizures in every patient with LGS? No, but in general, these get way ahead of the game for a lot of our patients. So the first one is start with the medicine that's actually been tested in LGS and approved. And I have to admit, when I started treating patients with LGS, the only options available was the unique and kind of odd indication that clonazepam has for atypical absence seizures, and valproate, while no historical approval, was the most commonly used drug, and none of the other compounds were available. So even though I agree with Anne in that we would like to see more robust seizure improvements than we've seen with many of our agents, I am very glad I have all the options I have, because it's made my life much easier than when basically I had valproate and nothing else from a medical standpoint. So go with the approved agent. Do we know which approved agent to do first? No, there's a lot of other factors that go into that. What's interesting when you look at the approved agent list is, other than our 2 benzodiazepines, and for the most part nowadays we really use clobazam as our sole benzodiazepine, but they all have totally different mechanisms of actions. So they're distinct chemical moieties, they don't overlap in mechanisms, and that may speak to the kind of breadth and width, if you will, of seizure types and even underlying etiologies that make up LGS, and why medicines that really have almost nothing in common with each other all can help here. So that may kind of speak to the challenge we have from etiology. There are other medications that are used, if you will, that don't have formal controlled trials. The ones that at least have some published data I've listed here. So levetiracetam has been used historically, zonisamide, lacosamide, and perampanel probably has the best, if you will, off-label data, just because it was started to be approached for use in LGS and is still being looked at in other countries. And we'll come back to that kind of later. So I've alluded to this, but obviously there's no evidence for even the approved therapy that one is better than another. They each have different side effect profiles, different drug interactions, so other factors that go into consideration. Can they be given through a G-tube or not be given through a G-tube? Do they come in a liquid form, or do you have to swallow them? So there's a lot of other factors that go into it that really have to be considered individually when we pick the medicine. All right, so let's move on to the second rule. So critically for the families, these kids are going to be on medicines for a long, long time, if not lifelong, is how do you deal with something that can make your seizures worse? And one of the things that we not uncommonly see is folks that, say, oops, we realize after the fact we missed medicine, or the child threw up a dose, what do we do? So really making sure that they know up front, kind of minimizing these kind of predictable, if you will, things that could increase seizure frequency. So if you use a medication that is an immediate release medication with a long half-life, or an extended release formulation of a short half-life drug, those should always be used, and that should be a key consideration when picking medication, because that gives you a lot of what we call end of dose forgiveness, where you don't risk kind of getting to the end of the dose and the blood level literally falling off a cliff and saying, uh-oh, now if we're late or we throw up that dose, I'm really in trouble. So unless there's a reason not to start with a long half-life medication or extended release, and that could be a simple reason, such as you have to swallow, it doesn't come in a liquid. So we should always be doing that. And then obviously the family should always know, depending on the formulation, what to do if they don't get all the medicine in, and to redose it, and how to do that. And that should be very specific and tailored to the family. We want to eliminate seizure triggers. Again, these are things that will help kind of knock our numbers down. We know certain medications can lower the seizure threshold in preschool age children. Diphenhydramine or Benadryl is a common one. We get to our adolescent years, Ultram, used primarily nowadays by our orthopedic colleagues to treat pain related to fractures, avoiding narcotics, but in our patients with LGS who are susceptible to falls, we still sometimes see that being used, or using immediate release bupropion for treating a mood disorder. The sustained release or extended release bupropion appears to be fine here. So this is a peak level effect. Sleep deprivation, mismedication, and obviously stimulation or kind of startle-induced seizures. We want to talk to the family and minimize those as well. We all realize, I think, that LGS is not a stationary target. This is not kind of childhood absence. We say, I need a few options. I know what this is. It's going to be the same. I can use these. These patients will change their seizure types, their patterns, potentially even their side effects as they get older. So we have to keep reevaluating continually, asking families, gosh, is this medicine still helping? Is it not helping? If they're not helping, we need to get rid of medicines. And why do we need to do that? Because one of the problems we see is these folks have a lot of seizures. So the bottom of the slide, they get their anti-seizure medicines increased. So we add another medication. They end up on lots of medicines that then increase sedation. And we know if you have LGS and you're sedate, you will have more seizures. So a lot of these patients are not what I would call fully alert and engaged during the day. Their eyes may be open, but they're kind of, couch potatoes, a little sedate. And if you improve that sedation, you can actually improve seizure control. And one of the ways to do that is by saying, gosh, if these medicines are not helping, can I back down? Where's the happy point between I need this medicine for seizure control and we're not sedate? And I realize that that's sometimes easier to say than to achieve in real life. We all have patients that are on more medicines than we would like, because every time we try and go back from 4 to 3 anti-seizure medications, thinking that, gosh, they're tired than we would like, they're napping during the day, can we back off those meds? We're not sure it's helping. Their seizures get worse and we kind of get stuck. So I'm not saying this is easy, but I think we have to continually be thinking about it and reevaluating kind of the burden of medicine for our families, not just because of the practical aspect of keeping up with all the medicines, but because of the fact that we could even be making seizures worse by doing it. All right, what about non-pharmacologic treatment? So many of our patients, exhaust pharmacologic therapy and need other options, or they need combinations of all these. And I alluded to this up front, that we have these kind of 4 silos. So we have, dietary therapy, all of the diets have been used. Device therapy, I'll talk vagus nerve stimulation, and then surgery is a option for some of these patients, but it's usually, there's a rare couple that this can be rare ones where this can actually be curative. For the most part, this is palliative. So let me just quickly kind of walk through these. So dietary therapy, our goal is whichever dietary therapy we can get to fit with our patient and family. What's the advantage of dietary therapy? We're trying to, change the central nervous system kind of energetics, and by altering chemistry, affect seizure control. We have ideas about how our dietary therapies work. Much like our medicines, we have some idea, but is it the ultimate answer? Probably not. Still an ongoing area of investigation. But the key thing is, I think for a lot of our patients, if they can do dietary therapy, it improves alertness along with seizure control, hopefully, without adding in a medicine. So we may not see side effects that we see with medicines, specifically sedation. The key, though, with this group, though, is we really don't expect folks with Lennox-Gastaut to be on dietary therapy for a period of time, a year or 2 years, and then come off of it, even if it's worked wonderfully, and maintain response. So if they do well on this, for many of our patients, they could be on dietary therapy for many, many years. And if they are, we've got to be especially attuned to monitoring for kind of long-term side effects once you get out past a couple of years. Obviously, if they have a G-tube in place, this becomes a very, moves more to the front of the line, if you will, for a therapeutic option. If it's an adolescent who has ideas about food preferences, this may be a hard one because of behavioral and other concerns to, approach. So again, we've got to individualize this within the family. Vagus nerve stimulation has been around for a while, approved now over 2 decades ago. There's multiple trials that were published over the years documenting efficacy, somewhat high responder rates, some median reduction. the Academy of Neurology, the American Academy of Neurology, updated their vagus nerve stimulation guidelines now almost 10 years ago. And one of the questions that the group was tasked with was the use in Lennox-Gastaut syndrome. And I've highlighted here, but you can see the Academy said that, yes, this is a treatment that we would recommend. It's efficacious in this group. And again, the advantage of this, do we think that adding a vagus nerve stimulator is likely going to get rid of all of our patients' seizures? No, but it allows us to add in a treatment that's not a medicine. So we kind of has a, it just does its thing in the background. It's kind of automatically helping for the patients that we have a positive effect. We may see other changes like improvement in alertness in addition to the seizure control. And if they're already on 3 medicines or 2 even, this kind of allows us to add in another treatment without adding another medication and getting into sedation and medication side effects. So for many of our patients, even the patients that they say, gosh, I was on 3 medicines, I added in vagus nerve stimulation, my seizures didn't get that much better. But if we were then able to lower their medicine burden to 2 medicines and maintain the same seizure control, patients universally tell us they're happier. And that's a really challenging. Anne was talking about, kind of regulatory hurdles. Try and get a regulatory body, convince them that that's a positive, that, you back down in 1 medicines. But our families, 100% of them view that as a huge leap as well. So surgical therapy. So this is probably still, when we do surgery in Lennox-Gastaut, the most common procedure, which is complete corpus callosotomy. So on the left, I've just shown you a sagittal scan. You see the nice normal corpus callosum here. And then after surgery, we can see that that's been completely interrupted by our surgeons. So nothing removed, just interrupted. This can be very effective for drop attacks and for convulsive seizures. So for the ones that are really disabling and result in injuries. And if we do this in the modern era, we're doing post-surgical tractography. So we do an MRI. We capture tractography imaging to really document that, our surgeon believed they were able to disconnect all the fibers of the corpus callosum, but this is a nice demonstration that we have no tracts coming the midline, crossing the midline after surgery. So we really can reassure the family that, yes, everything has been accomplished. There are rare patients that have a focal lesion causing their Lennox-Gastaut, and of those, probably a hypothalamic hamartoma that you see measured here on different MRI sequences is one of the more kind of common causes, even though it's incredibly rare. It's the more common of the rare causes, if you will. In the modern era, depending on the size, the nature and location of the hypothalamic hamartoma, it can be targeted with laser interstitial thermal therapy, which is you're seeing live here, kind of the therapy and how this is performed. So for folks that have this and it's identified early on, that can have surgical procedure performed, this can actually be game-changing as far as controlling all their seizures. And if you do that, usually preventing the progressive encephalopathy. Obviously, we all believe that we should look at all therapies. We shouldn't restrict ourselves to reduce the convulsive and drop seizures, because those are the ones that lead to injury. So when I see a new patient with LGS, I'm asking the family all the different seizure types, but I'm usually telling them up front that if they still are having convulsive seizures or drop attacks, that's what I'm going to go after first. Not to say the other seizures aren't important, but these are the ones that will end up injuring the child. Statistically, the most commonly cause of injury, and the ones that I really need to eliminate. And I'll use any of the options we just talked about to get there. So what else helps families? Well, we know these children are going to have intermittent bouts of increased seizure frequency. Their numbers are going to rise. So just like our patients with kind of asthma that our pulmonary physicians colleagues see, that have baseline medicines and they all have inhalers for when they get worse, all of our patients really should have an appropriate rescue therapy for when they get worse to supplement their maintenance therapy. In the past, Diastat was the only option approved in the US in 1997. We now have intranasal options that have been approved in the last couple of years. So there's other options, and for many of our patients that qualify age-wise for those are much easier for caregivers and families to do. Many of our families need more vigorous support at home, depending on the extent of the seizures. and some may even want seizure alarms for their sleeping loved one at night. MFIT, if we want it for nocturnal monitoring, is the one that I think we're most likely to be successful with for convulsive seizures. Both the MFIT and the Embrace-2 are what I call a shake monitors. So you have to have kind of shaking rhythmic movement to set those off. The advantage of the MFIT is it's a mat that detects micro movements that's placed under the mattress, so nothing touches our patient. The Embrace is physically worn, so for some of our patients that's problematic because they may not leave it on all night, and like any monitor, if it's not on, it's not very helpful. So these can give parents at least some sense of knowing what's going on with their loved one's sleep. And then Anne has alluded to this, but for a lot of our families, and especially as time goes on, the comorbidities become as important, if not more important sometimes, than the actual seizures, if you will. So with the Lennox-Gastaut syndrome, we focus on the seizures in clinic, but I think, we try and ask the family and walk through these at each clinic visit too. Are they sleeping okay? Are this, behavioral manageable? Are we still walking around? Are we having motor challenges that lead to falls and injuries separate from the seizures? Are we having feeding problems? So there's a huge list of other problems. And sleep is always one of the key ones that I focus on. It's one of the challenging ones. So I think we still have a lot of work to do on that as well. But we realize that these caregivers, if the child with Lennox-Gastaut, adolescent, adult is not sleeping, they're waking up the caregiver. The caregiver is the one responsible for keeping up with this patient, with their complex, medical needs, with the behavioral, all the other needs, feeding. And then we're asking them to do it after they've been sleep deprived, not just for a day or two or a week or a month, but for years. And I don't think any of us could put ourselves in that situation and function as good as we would want it to be. So sleep is a huge one that I think, unfortunately, has not been well addressed, and I'll come back to that as well. And then the final 10th one is we've got to constantly be monitoring from side effects of our therapies and long-term side effects, because these patients are going to be on medicines, most of them, for their whole life, right? So we know some of our kind of older or classic anti-seizure medications can have long-term side effects, so we are not using those in the modern world for the most part anymore. We have to monitor folks that are on topiramate and zonisamide because of renal stones. So if they don't drink adequately, if there's a family history, we might want to rethink that. And we've talked about dietary therapy, just the need to understand how to monitor long-term groups. So now that we've kind of gone through the basic kind of 10 principles of treatment, let's look forward now and say, where might things be going? Where are future therapies that are on the horizon that may help our patients and get us there? So I'll walk through these quickly in our remaining minutes, but new kind of anti-seizure medicines, rescue, device therapy, monitoring, and kind of treatment of the comorbidities and where we could be headed. So there's a couple of compounds here. So Kerosbal, we'll see if it still uses this licensed brand name, Confide. It had that in the past. It may not keep that. But this was a drug that Johnson & Johnson looked at over 10 years ago now as a treatment for partial seizures. Their trial for that, because of the lack of consideration that this drug was susceptible to enzyme induction by other seizure medications that could affect CYP450 systems, was not positive. It was denied. They were licensing that drug from SK Life Sciences, and SK Life Sciences has restarted trials with that drug just recently with Lennox-Gastaut. So we'll see what those who are going forward and if there's any further information even at the American Epilepsy Society meetings this year. Perampanel I alluded to. It's approved in many countries for both partial seizures and genetic generalized epilepsies. The company began trials in 2016 to look at the Lennox-Gastaut. And for those of you with a good memory for dates, you realize that that was a problem because that was about the same time the cannabidiol trials were being done for Lennox-Gastaut, and everybody wanted to be in cannabidiol trials because that was felt to be the cure for everything. So those studies basically in the US were finally stopped in 2020 because of lack of recruitment, not because of efficacy or side effects. They are ongoing in other countries, mainly in Europe and South America, as expanded access programs. So we'll see what those countries' data ultimately shows us. They may have LGS approvals in those other countries at the end of the day down the road. Benfloramine is a drug that's been around for ages now. It was developed in France in the 1960s, so for 60 years. It was approved in the US in 1973 as an anorexic agent. It was used widely in the US and in Europe. And by the 1980s, estimates 20 to 60 million people worldwide on this drug. But then in 1997, it was realized that in higher doses than we're currently using for epilepsy, and much higher, often 4 to 8 times higher, this could cause a very unique valvulopathy from one of the metabolites, effect on the receptor that's on the cardiac valve. It was voluntarily withdrawn from the market. However, in the modern era with Dravet and with an animal model, the idea that this worked there based on clinical observation was tested in the animal model. It was very robust, so Zogenix brought it back to the US market to be used in Dravet syndrome. They did the trials that led to approval. It's now being used commercially for that. They have done a trial, a single one in Lennox-Gastaut. You see their patients listed here, but they looked, and this was presented by Kelly Knupp, one of the lead investigators at last year's AES virtually. So since it was virtual, unfortunately, many people are not aware of that. But the one I wanted to highlight, and this again gets back to a point that Anne talked about, is you have to pick your endpoints carefully, because in most LGS trials, drop attacks are the primary endpoint. And you can see that while this kind of helps some, it was not as robust as we would like to see in drop attacks. But in generalized tonic-clonic seizures, even the low dose and the high dose, and I think these colors are switched on me somehow, but maybe not. I'm just trying to see why low dose is higher, just notice that. Anyhow, both had robust efficacy and dramatically better than in drop attacks. So this may be a really good drug for convulsive seizures in Lennox-Gastaut, although if we get approved for use here, we may want to use some of our other agents if the drop attacks are the primary problem. So again, knowing kind of where the drug fits and the seizure types the patient's having. So we'll see what happens with this drug going forward with the FDA as well. Side effects we know, because it's been around forever, we're using it, so we know the common ones. It does require cardiac echocardiogram monitoring every 6 months as part of a REMS program. So far, since clinical use and in all the studies, there's not been a single cardiac valvulopathy reported at the doses we're using in epilepsy. Very different from the prior doses, so keep that in mind. Another new drug, potentially, we'll see what happens with this drug, is OV953. You see its other name here. It's an interesting drug. People realize that in the brain is very unique in that cholesterol is made, we all need, cholesterol, fats in the central nervous system. It's a very good, myelination agent, and it's utilized in the brain. We have a lot of need for it there, but it's made within the brain itself. It's not imported, if you will, from the liver by the bloodstream. And then if you have too much of it, this enzyme, cholesterol 24-hydroxylase, converts it to a 24S enantiomer, hydroxycholesterol, which then can diffuse out to the blood vessel and be removed. So it's a way to get excess cholesterol out of the brain. The way that OV953 works is by inhibiting this enzyme that lowers the amount of 24S hydroxycholesterol. By lowering that, that agent actually also has a kind of positive neuromodulatory effect on the NMDA channel, which is excitatory. So you kind of decrease the excitatory component to the brain and improve seizure control. There's one trial that's been performed. You see in 88 patients. Unfortunately, drop attacks, while better than placebo, did not achieve significance. Very well tolerated for the most part. So we'll see if this drug, if we can kind of figure out better dosing and how to get there, that this drug gets a very novel mechanism, ends up being something that we use in LGS. All right, rescue agents on the horizon. There are two. One of them I'll mention, I don't have a slide here, which is a oral buccal soluble film version of diazepam, so it would allow you to have another non-rectal route of diazepam other than intranasal. This is a unique one that trials are just starting in epilepsy, so not specific to LGS, but it uses a benzodiazepine, alprazolam. It's impregnated. You see where the drug coating is here. When this is placed up to the patient's mouth, all they have to do is take a breath in. So even if they're not kind of fully with it, if you will, they're still drowsy. If a caregiver can hold it up to their mouth, get their lips around it, if they can take a breath in, that will heat activate. They inhale the drug. And keep in mind that our lungs are a huge source of drug absorption. That's why asthma patients all have an asthma inhaler, because it works so good at getting medicine into the body. So we'll see if this continues to move forward. Like I said, trials are just kind of going on clinically now. It could be another rescue options in a couple of years. All right, what about other options that are not medicine? I think this was alluded to too. So device-based therapy, we know we look at mechanism, and I think Anne showed a nice slide of kind of functional MRI changes looking at connectivity, but people have also used those to look at interictal EEG and Lennox-Gastaut and say, they have slow spike wave, they have paroxysmal fast activity. What's the generator for those? Is that the same as, kind of regular epilepsy, if you will? And the bottom line is you see very different activation, often in thalamic and subcortical structures, not cortically. And we know the central median nucleus is a key nucleus in regulating kind of motor cortex tone. So the Velascos in Mexico City years ago used this. They looked at patients that had atypical absence and generalized tonic-clonic seizures. They were Lennox-Gastaut patients. And you see, showed really dramatic improvements. And at 6 months, they all had reductions in convulsive seizures. When they had their batteries end of service, they came back up, but when replaced it, they did dramatically better. And what's interesting is their patients that have the worst convulsive seizures seem to respond better also. So this is a video, hopefully it'll work, that the Velascos were nice enough to let me borrow and utilize. But this is a patient that an infant had herpes encephalitis, developed LGS. They were doing a testing prior to placement of the central median nucleus. They're just being asked to copy standard figures you see on the right side, so trying to adapt neuropsychologic testing. So the one on the left of the screen is our patient. Oh, darn, it's not playing. Okay, well, what you would have seen, let me see if either of these will play. Okay, the one on the right is thinking about it. Okay, so you can see the one on the right is after we have our central median nucleus stimulator in place, that we're flying along through those. The one on the left that's not playing, what you would have seen is basically nothing. The patient is really struggling and you don't see much more than there. So basically what I was hoping I would demonstrate here is this really does show that beyond seizures, the effect on other functions that I think Anne alluded to as well. And then if we're going to do device therapy, we have to tailor a device to the pathways of the epilepsy in a given patient. All right, other options. This is a unique one that is, again, just being tested in the United States. It's named Nelly. It's a way to do nighttime seizure monitoring using artificial intelligence in real time. So the challenges we have, our patients, asleep at night, that really worries our families. If we have a device touching them, many of our patients would take it off. So with the Nelly device, this is our patient asleep. It's actually here. It can be sit at a bedside table, or it can be like on a lampstand kind of looking item here. It basically has an infrared camera, so it can even monitor movements, micro movements through a blanket, so you don't have to be fully covered. Those are transmitted live to artificial intelligence, and that artificial intelligence has a bank that has tens of thousands of movements of patients in their sleep in it, and it is cross-referencing. So if this is our loved one, if they just roll over in their sleep, it's analyzing that and saying, oh, that fits with what we have in our database. That's just someone rolling over in their sleep, no alarm. If they started to have a series of myoclonic jerks, if they had a convulsive seizure, hopefully even if they had a tonic seizure where their arms elevated off the bed stiffly, it would say, wow, that's not a normal sleep movement. An alarm would go off and it would alert a loved one. So this is just in the validation studies now. being done in the US, so we'll see where that goes. But for a lot of our patients, this would be very helpful because it would be a way to monitor for multiple seizure types, not just those that have a jerking component in our patients while they sleep naturally in their own bedroom. All right, let me just finish up with other treatments and needs. I've talked about this before, but I think this is a totally ignored area. We desperately need better treatments for the sleep disorders these patients have, and it's probably one of the key ones that their caregivers tell us they would like. We need better defined treatment algorithms and sequencing steps. Now that we soon will have potentially 8 new medicines for LGS, we can't go through all 8 of those before we get to non-pharmacologic therapy. How do we make decisions about that? How do we start to think about it? I think we need something for that for LGS, much like was proposed for Dravet a few years back. We clearly need access for these families for mental health professionals, behavioral therapists. For many of our families, there's just no one where they live that can provide this resource. And we need family physicians, whether it's pediatricians, family providers, internists as they get older, who will actually care for the routine medical needs these families have. Many of these families just have an impossible time even getting routine medical needs cared for because local doctors are kind of overwhelmed by the complexity of their epilepsy and their syndrome and just won't even see them for routine needs. So let me stop there. That was a really quick tour through it. We're going to all do questions, I guess, as a group here in a minute. So I'll thank you for your attention and hand it back to the moderators.
Super. Thank you so much, Jim. That was really comprehensive and clear. And clearly, we still have needs for novel interventions. There are a couple of questions specific for you, and then I'd really like to move on to a more general discussion with all of the speakers. Quickly for you, are there treatments that are better for nocturnal seizures in LGS? And then secondly, is there data on the effectiveness of deep brain stimulation?
Yeah, good question. So maybe we'll go backwards. So deep brain stimulation has not been used in the US in any form for Lennox-Gastaut and is not an approved form in the US. In other countries, as I talked about, what the Velascos did was basically a form of deep brain stimulation, if you will, just targeting a different nuclei. So I think they're down the road, probably is a role. We just need better defined targets at this stage of the game. Nocturnal seizures are tough in LGS. They're probably some of the toughest ones we treat. What usually works the best is targeting the seizure type, because in the past we kind of maybe naively thought that if we made the patient's medication dosing uneven, so for example, they got a third of their daily medicine in the morning because they did better for seizure control during the day, and they had more seizures at night, we'll ramp up your nighttime dose dramatically, that would kind of take care of the problem. And for many of our patients, that does help them some because they achieve much higher levels at night, and sedation is not an issue, if you will, related to that. While it may help some, for many, that does not get rid of them all. There's still a huge problem. And that probably relates to some of the, again, it goes back to some of the pathways, some of the normal inhibitory pathways that are fully activated when we're awake and that part of the brain is engaged are not there when we're asleep. And we have a harder time then controlling seizures.